Stanford University.
Also very high percents, just to get a sense of what is the population looking like. This is all US data, these are all US data, by the way. And at this point, we see that men are exceeding women slightly when we get into these higher groups. But hopefully you've been also paying attention to your age group as you go along here, just to get a sense of how you feel. I'm over on this side, so I'm looking at the 80 plus. But if you're going over here, you can see how this is increasing very, very rapidly as we go through these 20-year increments. So when we talk about cardiovascular disease, it is the leading cause of death among women in the United States. And actually, it's the leading cause of death in most developed countries. 1 in 2 deaths, so half of all women will die from cardiovascular disease using those broad definitions. Kills more than 500,000 women each year. Kills 6 times the number of women that breast cancer kills, and almost twice as many women as all forms of cancers put together. And 1 in 4 women actually have coronary heart disease. 1 in 4 deaths in women are from coronary artery disease. So just to get a sense, it's not just an issue of older women. It's the second leading cause of death for women 45 to 64, and it's the third cause of death for younger women, 25 to 44. So it's a huge issue, and a lot of women don't know it. We still have this problem that people still call it a man's disease. And I do a huge study of men on osteoporosis, where everyone calls that women's disease. 1 out of every 3 hip fractures is a man. So we have to get rid of this gendered bias about these diseases. They can basically get men and women, and we need to be becoming educated. Now, when we talk about this, there are clearly differences by different ethnic groups. In this particular slide, we can see the black men in blue and the white in red. So you can see there's minor differences there. Much larger differences when we look at white women in yellow and black women in the light green. And this is now the incidence of a heart attack by age, race, and sex. And to just look at the first heart attack, you see the same thing, that white women are clearly the lowest. As we age, it's increasing. Black women are next, and then we have the 2 male categories. Now, some of the issues about heart disease, we're going to talk about some areas that really are just now coming to light. One of the big problems is under-detection. So there's a lot more heart disease out there than we realize in women, and one of the problems is symptoms. So women have kind of different symptoms than men. They're more subtle versions of male symptoms. They also report other things: abdominal pain, back pain, nausea, shortness of breath, and fatigue. And other than shortness of breath, I think most of us experience many of those things often. So how do you distinguish that from heart disease? And that's a real challenge. Now, I put quotes around typical because that's a real male perspective. This is the typical male symptoms. And it's just a little hard to figure out what is typical. But if we look at younger women, and one of the things I'm going to be pointing out to you is that there's a really big difference between heart disease in younger women and older women. Heart disease in older women is very much like heart disease in older men. But when we're talking about younger women, we have some really different issues that have gone undetected until the last 5 or so years. Chest pain is most common, but it's a little atypical. It's a chest heaviness, a pressure, tightness, or squeezing. But 58% of women have pain in the jaw or shoulder. 38% of women sweat. 29% experience nausea. 29% have shortness of breath. 21% have indigestion or heartburn. And they often are sent away with Pepto-Bismol or something like that when they're having a heart attack. And then weakness and fatigue is also 8%. Now, an interesting point when we talk about gendered medicine is the fact that there are delays for women every step of the way. If a woman starts to have this experience of a heart attack, she may call 911, and it turns out that the ambulance takes longer to get to the woman than to the man. They basically are not aware that women could be having something that needs the same urgency. So 52% more likely that they're going to have a delayed ambulance coming to them. Once they get to the ER, the door-to-balloon time, which is from the moment you arrive until they actually get a balloon into your artery, is much longer in women. So we have all of these problems that basically we need to fix, because we need to get everybody to recognize that this is something that could be happening. Another quick set, and then we're going to get into a little more meat, is that it turns out we have lots of different reactions to medicines, and they have different preventive benefits. So for instance, aspirin, which we recommend to men at a low dose, does reduce coronary heart disease in men, but it turns out from the data we have so far, and lots of people debate this, it's not true in women. But yet we do recommend that you take a low-dose aspirin from age 65 on. On the other hand, aspirin has been shown to reduce stroke in women, but not in men. So these are some really interesting issues. Also, we know that some of the drugs increase arrhythmias in women much more than they do in men. And there's actually a particular kind of arrhythmia. So quinidine actually causes, it's an antiarrhythmic that causes this really slow Q wave. So this is called torsade de Pont. And another one to just quickly mention is atrial fibrillation. It's much more common in men, but if women get it, they're much higher risk of getting a stroke and having some bad outcomes. And these are the kinds of things we're looking for. Now, there have been huge campaigns. I think if you've been through San Jose Airport in the last 10 years, you might have seen some of the red dress campaigns, because they actually had this set. And there's some interesting political battles between the National Heart Lung Blood Institute's red dress campaign and the American Heart Association's red dress campaign, but they all seem to recognize that a red dress is a great way to make the point that we need to bring heightened awareness to women's cardiovascular disease. And basically, when we look at now, this is deaths in thousands, so this is not a percent or a rate, it's actual numbers. What we've been aware of is that these deaths in thousands have been dropping in men over time. And for quite a while, they weren't dropping in women, and that was really seen as being an alarming issue. The good news is that they are now dropping. Now, to some extent, this relates a little bit to the interaction of smoking and heart disease, because it turns out that men were smoking at much higher rates, and then they've been slowly dropping. And in World War II, women started smoking, and so they just started to get the consequence of that, the heart disease, and that was really kind of hovering here, and now they're dropping because their smoking is dropping. So it's a little confusing how these data look, but this is actually a really interesting slide that's looking at 52 countries that go from a really low rate of cardiovascular disease. So the far end of this, Japan is the third one in. So Japan has a really low rate. And we get up to the higher ends where we have Northern Ireland and Scotland, and the US is in here somewhere close by. And what you see is that when we go from a low rate to a high rate, nonetheless, the difference between men and women, it turns out to come out to about 2.24, whether you're talking low rates or high rates. So it's just steadily climbing, where what we see is the male rate relative to the female rate for these diseases. So it's a really robust, it's not just one sociocultural experience, it really does seem to have some probably biology basis. Now, that said, I'm not going to become a man, and the men in the room probably aren't going to become women, although we can do that. Nonetheless, the point I want to make is that within ourselves, within each group, we have the percent of total deaths due to different diseases. And so the first thing I want to point out is that for both men and women, the #1 cause of death is coronary heart disease. And it exceeds all cancers put together. And then you can kind of march your way down. So stroke has a higher totality, it has a higher rate of deaths for women than it does for men. That's at least in part because men are having deaths from accidents at higher rates and lung cancer at higher rates. So all of these death things take into account competition. You can only die from one thing, and so which one is going to get you? But it seems that heart disease is getting the vast majority of, or a much higher percent of both men and women. Now that's the overall picture, so that's from birth until the end. I do want to point out that this is true in every single race ethnic group in the US. So heart disease is a leading cause of death in whites, blacks, and Hispanics. Now, it's not true in Asian, but it actually is the case that they have much lower rates if I was not looking at percent within the population, if I was just looking at the rate. And they actually have lower cancer rates than the other groups, but the total effect of cancer. That said, there is no individual cancer that comes anywhere close to coronary heart disease. So this is pretty universal, also true, very true of men across the board. So this is something that all race ethnic groups can recognize that we need to be paying attention to heart disease. Now, to just home in on the fact that most people, most women, the majority of women are dying at age 80 up, here's where the big toll of heart disease and the big numbers of deaths is occurring. We don't have as many men dying by now because they already are gone, and we'll get to them. But you still see this very high rate, and it certainly exceeds all cancers in these older groups. I will point out that Alzheimer's disease appears in the 80-plus group for both men and women, and stroke does. And one thing I'll quickly say is, I'm not going to spend a lot of time talking about Alzheimer's, but when you actually start to look at what do people believe for preventing Alzheimer's, it looks exactly like preventing cardiovascular disease. It's all the same stuff. So people are basically homing in on the one thing we can do is try and keep our blood vessels healthy so that we have our best chance up there. When we talk about the younger groups, so the middle-aged and slightly older men, we actually do have all cancers exceeding heart disease in those groups, but then again, no individual cancer. So lung cancer doesn't come anywhere near heart disease. Accidents actually exceeds lung cancer, by the way, so that's a big part of our prevention message, is trying to prevent accidents. And then really, since the focus is women, I wanted to really highlight the fact that I'm not giving you enough time to study all of these. I think they go online, so you'll be able to look at them. But to make the point that many more men, by the time we hit 48% of men had already died, only 4% of all the female deaths have happened. And this is also true when we get into the next age group. This would be 18% for men on the last slide and 11%. And it's not really until we get into the 60 to 70 that we're kind of equaling out on the percent of deaths, but that's really just all math. But what I wanted to point out here is that a lot of people have homed in on this when you kind of curtail the data so that you have a point and you go to 40 to 40 and it's a category and you put one point there and then you go to the next point, you get this really steep increase, and many people have tried to associate this with menopause. And in fact, when I was going through a lot of my graduate or postdoc work, every article would start out, women are protected against heart disease until they go through menopause, and then all protection is lost. And we just saw that over and over again. And that's a really interesting thing if you're interested in women's health. And so I started to try and find out, well, is that true? Is it really that menopause is a risk factor? And there are several analyses now, but there was one done actually back in 1998 in the British population that tried to examine this. And here you see men starting off with their heart disease. This is actually death, so coronary heart disease death. They're having their deaths about 10 years ahead of women. There's menopause. There's really no evidence when we put this on log scales that menopause is making any kind of real impact. And if I showed you breast cancer, you would see a very clear impact. Basically, the breast cancer rates are very steep until menopause, and then when you don't have your estrogen on board, they're still going up. So age is still higher, is a big risk factor, but you can really see the inflection from menopause. But you do not see that with heart disease. So that seems to be a myth that we're probably not going to get out of the literature for a long time. And an interesting point, actually, to go back here, you can actually see that the 15 to 19 group, there's already more heart attack, more deaths from heart disease, very low, but more in boys than there are in girls, so already at puberty. And an interesting phenomenon at puberty is that at puberty, the HDL in males drops. And that's the reason that we have this 10 milligram per deciliter difference between men and women. It's not because of estrogen. Even though estrogen can raise your HDL, the sex difference that we see in this particular lipoprotein is really happening in males going through puberty. The LDL situation's a little more complicated, and I don't have time to go into that. But because of this myth, a lot of attention was taken to menopausal hormones and the idea that the way to prevent heart disease in women was to give them menopausal estrogen. And there were lots of observational studies of various quality that were weighing in on this. Now, the most interesting thing is that right when I got interested in this question, it was 1985, the New England Journal of Medicine published side by side, and I'm sorry these aren't lined up quite right, but the famous Framingham study, which I'm sure many of you have heard of, and the famous Nurses' Health study. And they had absolutely opposite results. So the Framingham study said that women who were taking menopausal hormones had twice as much heart disease, and the Nurses' Health study said they had half as much heart disease. And so it came out as a controversy, which is really exciting. So Sophie knows that's the kind of stuff we love to go for, like, well, who's right? And so at any rate, the bottom line is the bulk of evidence, and because of studies like this, we now have to register trials because we've learned since that there were a lot of trials that never made it into publication. We have publication bias. Any of you who know Johnny Anitas, who's now the director of our prevention center, can tell you we have so many problems with what makes it into the literature and what doesn't. But at any rate, the literature was pretty heavily presenting the idea that estrogen was protective, and there was almost no data on estrogen and progestin, which, just so you know, if you have a uterus, you take both. You take estrogen and progestin to protect the uterus against cancer of the uterus, and if you have a hysterectomy, you take just estrogen. So we actually had a big question. I'm going to give you a little bit of information about that, and then we'll get back to classic risk factors. But in that, I did spend a lot of time working on this question. One of the issues with observational studies is they're biased because of your preferences. The women who will take hormones and keep on them feel better on them, and lots of women start them and get off them. And so what you have right off the bat is people who are reacting to them differently. And we know that back in that old literature, the majority of women who are taking hormones, most of them stopped 2 to 3 years. So the majority of women did not continue taking them, whereas the women who continued taking them was this healthy user group. As a group, they were less obese, they were more physically active, they went to see their physicians to get their cholesterol checked. They also were getting mammograms, so we were detecting a lot more breast cancer, so that was just kind of a fluke of the testing situation. But at any rate, we were kind of left with, is it really protective, or is this just a coincidence from the data? And I can tell you that I spent a lot of time marching my way through these trials. The first one we did was called the Pepe Study. And this study was complicated. It had 5 treatment arms. We actually designed it with 8 to begin with because we wanted to study the patch as well. But for reasons I won't go into, we weren't able to do that. But it was, by today's standards, very small. It was the biggest study ever done of this question at the time. So this was published in 1995. And the bottom line is that things that we were calling traditional risk factors seem to have some favorable effects. HDL cholesterol, the good one, went up. Fibrinogen didn't go up. LDL went down, the bad cholesterol. We had some neutral, no effect on blood pressure, insulin. But we also had unfavorable results that people didn't want to talk about. And in fact, triglycerides was one that, because it hadn't been shown in Framingham or the Lipid Research Clinic, which was one of the original, the 2 trials that had men and women, it didn't show up to be a risk factor in men. It was just discarded as not important. And what I'd like to show you is that, in fact, the LRC was able to demonstrate, so this is an old paper, so it's an old graph, but basically what the LRC was able to show is that in women who had a combination of high triglycerides and low HDL, they had really high risk of coronary heart disease. And that wasn't seen in men, so we never even got triglycerides built into our modeling. I will also point out that HDL was really important in both the Framingham and the LRC for women, to the point where it didn't matter if you had low or high LDL. What really mattered was whether you had low HDL. Low HDL gave you high risk for heart disease as a woman, and high HDL gave you low risk. And it's also true of men. We just don't have good drugs for it, so you hear only about LDL and statins and things like that. Now, one of the questions that people asked in this hormone arena was about women who have heart disease. Should we put them on estrogen to prevent another event because they're at the highest risk? And so the first big trial we did with real outcomes, heart outcomes, was the HERS trial. And this HERS trial was only for women with heart disease. It was a 4-year study. They were randomly assigned to a combination of estrogen and progestin in the form of conjugated equine estrogen and medroxyprogesterone acetate, which is Prempro, which was the most commonly prescribed estrogen-progestin combination at the time and still is, or placebo. And as we had seen in Pepe, we got these what we would call good outcomes for HDL, increasing the good one, decreasing the bad one. Again, this increase of triglyceride, which we did not see as a favorable event. But in fact, after 4 years, there was really no difference in the overall heart disease, the cardiovascular events. However, in the first year, there were 52% more heart attacks in the women who went on these hormones. And I should just let you know that the year before we published this, the American College of Cardiologists put in their recommendations that if you have a woman who's had a heart attack, you should put her on estrogen or estrogen and progestin to prevent a second event. So that was a recommendation for cardiologists, and it turned out that in that first year, more women on those hormones would have had a heart attack. So we really were going the wrong direction on preventing heart disease in women with this motto. Now, lots of people criticized that, and I'll just tell you that within the next year and a half, all kinds of people came out ready to publish the fact that, yes, well, we studied the same drug and we saw no benefit by angiogram. We studied a different estrogen, 17-beta estradiol for stroke, and we actually saw early strokes, no benefit. Another group did a patch looking at an estrogen with a different kind of progestin, also seeing possible early harm, no benefit. The WAVE study was using angiograms. They also had vitamins, possible harm. So over and over and over, within a year and a half, boom, 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 was the idea that no, if you have cardiovascular disease, you don't start estrogen. But what about women who don't? So I can tell you at this time, lots of people were very upset. They were really holding on to the idea that hormones are protective, and gave us all kinds of scientific reasons why this should work. And so the question is, okay, that's great. That's a good reason, but does it? And so we had a puzzle to solve. And we basically, I put in quotes HRT. We used to call it replacement, hormone replacement therapy, as if all of women needed to have it. I don't do that anymore. We just call it hormone therapy now. But at any rate, we knew that it was great for taking care of menopausal symptoms, but we didn't really know, is it a good thing for preventing diseases of aging? And that really was what was happening to women. So women's health was very much about get them on estrogen because you want to prevent heart disease and strokes, and there was concern about blood clots because estrogen has been shown to increase blood clots. But certainly for bones, it was seen as being beneficial. There was concern about breast cancer. Many people believed it was good for memory and Alzheimer's disease, and we didn't know about these other things. And so the Women's Health Initiative happened. And this was a huge effort. It was actually a woman cardiologist who was the director of the NIH at the time. And she went to Congress and made an appeal that we would get the funding to really look at women and heart disease, which hadn't been done. So this was a huge study. I don't have time to take you through all of it. But bottom line is if a woman had had a hysterectomy, she would basically be put into the estrogen-only trial. She doesn't need progestin. She doesn't need to protect a uterus. But she would be assigned to the estrogen in the form of Premarin or placebo. And if she still had her uterus, she'd get the combination of estrogen and progestin or the placebo. So this was HERS, but on healthy women, and then estrogen only. And the hypothesis was based on all the observational literature we had at the time. And to just kind of do it in a schematic way, basically we had stopping rules. If in fact the belief that was on pretty much everywhere that we could prevent heart disease and we could actually reduce heart disease by 30%, then the idea would be that we would stop this if that benefit occurred because that would not be fair to give to the placebo women. On the other hand, we also were worried about breast cancer, and if in fact it was harmful, then we would want to stop for harm. But we actually built into this the whole woman perspective. We weren't going to stop just for benefit to heart. We weren't going to stop just for harm to breast. You had to have an overall picture that it was either good or bad. So it was really unique in how it was done, and this is why it got so much attention, I think. But we didn't know what was going on with stroke. The observational literature was all over. We didn't know, is this good or bad? What do we do about that? And I will just quickly tell you that this was meant to be a study of older women. It was not about menopause. We already knew estrogen's great for taking care of hot flushes. We wanted to know, is it good for women's health? And so we had the goals for women in their 60s to 79, which was going to be the majority, and we had limits about how many younger women, 50 to 59, we would bring into the trial. And this is true for both trials. So one is the estrogen and progestin trial, and the other is the estrogen-only trial. And the other thing is that we were very determined to have minority women in the study. And an interesting phenomenon is it turns out that minority women get hysterectomies at younger ages in the United States than do white women. By the time all is said and done, I think it's pretty equal. But because of that, we had a much higher percent of minority women in the estrogen-only trial. And I'm only saying that because there's a few caveats I'm going to hit you with in a moment. But the first thing is these were two different trials. And the estrogen and progestin trial, so the trial where, if you remember, we didn't have a lot of observational data on this combination. We just had the data on estrogen only, but we were giving every woman with a uterus this combination. And so the first thing that happened was the preset stopping point for breast cancer was hit much earlier than we expected with a combination. That would not have stopped the trial because by that time we actually had fewer hip fractures and we had a surprising decrease in colorectal cancer, and those would have balanced each other out if in fact our cardiovascular hypotheses were not completely wrong. So the reason why this study, if you remember it, it's already been almost 10 years now, got huge press because instead of preventing heart disease, we had 29% more heart attacks. And we had 41% more strokes, and we had the blood clots that we weren't surprised about. But the overall picture was clearly one of harm, and we were doing this as our primary prevention focus for women. So that was a big mistake. I will also quickly tell you that we had a study within the study of the older women, so women 65 and up, looking at probable dementia, and we actually had one within each of the trials. And to everybody's surprise, instead of having less dementia, we actually had twofold increase. This is the active group relative to the placebo. The stepping, by the way, is because we were only doing the cognitive tests once a year, so you didn't find out until you did the test that, whoa, these women were twofold higher, more likely to get dementia on this hormone.
Dementia or Alzheimer's?
Well, you know, it's probable dementia and it includes Alzheimer's. About a third of it was full-blown Alzheimer's, and about a fourth of it was vascular dementia, so it's a combination. Now, this got a lot of press, and so not only did it get a lot of press about we shouldn't be giving this to older women, but lots of attention finally to menopause, which we won't go into right now, but that was before we even had the estrogen-only trial finished. The estrogen-only trial did not see an effect on heart disease and did not see an effect on breast cancer or colorectal cancer, but what happened was we ended up having, again, a huge increase in strokes and some blood clots, and that even though the benefit to hip balanced it out, this was funded by the National Heart, Lung, Blood Institute. They weren't ready to continue a study on stroke. So the bottom line is we learned also with dementia that this was a much higher, it wasn't quite significant, dementia and something called mild cognitive impairment. So the bottom line was this was not the right thing to be doing to prevent heart disease. And to just quickly say a few things, if we look at where did the two trials come out the same, they showed no benefit for heart disease, and then for the combination, it was early harm. For stroke and blood clots, both studies showed harm. Both studies showed benefit to bones, which continues to be a challenge for us, and both studies showed harmful events for dementia. What was different was breast cancer was actually increased in the combination estrogen and progestin, but not in the estrogen only. And then colorectal cancer was different. And the global index, which was this balance of all the information together, was one of harm for combination therapy and neutral for estrogen only. Now, basically, we solved the puzzle. I'll tell you, we also saw that gallbladder disease was increased on the hormones, and incontinence was increased. But a lot of attention went to subgroup analyses for heart disease. And to just kind of walk you through this a little bit, there was no difference between the estrogen-only group and the placebo group in terms of the total events. But when we broke it down by age group, a lot of people focused on these younger women having fewer heart attacks relative to placebo. And even though this wasn't significant, a lot of attention went there. Now, I can tell you the pharmaceutical company played a role in that, and nobody paid too much attention to the fact that what was also driving that interaction was much higher rates, or at least higher rates, in the older women on the active hormone, on the active estrogen relative to placebo. But a lot of attention went into that, and we came up with, there was this timing hypothesis that came along, and I only bring it up to let you know that when you really look at what the timing hypothesis says, it doesn't say that younger women benefit. It says that compared to older women, they're better off, that older women are clearly harmed by going on this, and that's really what the message should be, but that isn't quite what we hear. And I can tell you that why did the two trials differ? There's lots of reasons. It's not just because one had estrogen and progestin and the other had estrogen. We had much more obesity in the estrogen-only group. It turns out that in the population, women who have had a hysterectomy are more obese. Part of the reason they're getting hysterectomies is because of uncontrolled bleeding, which happens with obesity. So there's other reasons that these two trials differ, including the hormone history, but I don't have time to go into that. All I want to say is that when we actually put the two trials together, we saw some other things that I think are important for women to know, and that is that women who are starting the hormones close to menopause seem to be not so, there's really not the same danger, clearly, as there is starting it distant from menopause. And so we feel that, yes, we can give some reassurance. We wouldn't say stay on it the rest of your life. But what was really interesting is that it turned out that older women who had hot flushes, and about 9 to 10% of women continue having vasomotor symptoms on into their 70s. That group of women were the most harmed by going on the estrogen and progestin. So it's not something that older women should start if they're having those particular problems. And stroke was increased regardless of age. Now, I will tell you that lots of women came off their hormones at that time. We also made our women come off. And so we were able to see what happens when you come off. And just to summarize a long story and make it short, the cardiovascular risk disappeared within 2.5 years. So we no longer had increased strokes and blood clots. Well, there's a little question about stroke, but there was no more problem with blood clots. And I won't take you through all the rest of that. Similarly with estrogen only. Now with estrogen only, we do still have this hint of some benefit for the younger group, which is where the literature was. So I'm going to tell you right now, there's something different about older women and younger women, and you're going to hear a lot more about it now. I will tell you also that the American Heart Association viewed all of the data and basically said in their most recent guidelines that look at women's issues specifically that interventions that should not be promoted for prevention include menopausal hormone therapy. We should not be prescribing this to prevent heart disease in any age group. There are some other ones I'll just quickly mention. Antioxidant supplements, vitamin E, C, and beta-carotene. We have no evidence that they're beneficial to women to prevent heart disease, and in fact, there's some suggestion of harm in certain subgroups. Folic acid with or without B6 or B12 supplementation, and then I've already mentioned aspirin if you're younger than 65. So these are some of the kind of current guidelines. Now, to make a little segue here, when we start talking about causes of death, from a prevention perspective, you really want to know what's the behavioral cause? What can I do to prevent these diseases? So this is basically looking at lifestyle factors, and I'm going to talk a little bit about them. Tobacco is the #1 bad thing for men and women combined, Poor diet, physical inactivity is next, and then we have alcohol consumption, microbial agents, toxic agents, motor vehicles, those accidents, and firearms for the suicides, which is a really high cause. And there's a really interesting recent analysis. This pulls all the men and women together. I'm going to show you the sex differences in a moment. But trying to look at what is attributable, what are the deaths attributed to when we look at cardiovascular, which is in black, cancer, which is the striped bars, diabetes in yellow with dots, respiratory, which is blue, other chronic diseases, and non-communicative chronic diseases, and injury. And so what you see is smoking is leading as the cause of death when we pull all the chronic diseases together. Then comes high blood pressure, and that's all about cardiovascular. So I already showed you how high blood pressure is, especially as we age. And when we break this into men and women, I'm going to focus on women, and those of you who want to look up here can look up here. But you'll see that the #1 cause for women is high blood pressure. This is a really important thing for us to get under control. The next one is smoking, which is basically impacting cardiovascular, cancer, diabetes, and respiratory. Same with men, but it's a much higher problem because of higher smoking in men. Then comes high blood pressure in men, so it's just flipping the two. Then the next one for both groups is, well, okay, the next one is for men is overweight, obesity. For women, it's physical inactivity. And so I want to talk a little bit about that today, and then comes obesity, and then high blood glucose. I'm not going to walk you through all the, well, I guess I will. High sodium, LDL cholesterol, dietary omega fatty acids, high dietary fatty acids, fatty acids, and then comes low vegetables and fruits. And so all of those are black, pretty black for cardiovascular. So what's your risk? This is essentially the kind of question that you would ask, and we actually have special algorithms now to calculate your risk. The Framingham 10-year risk score is one of them. But I'm going to kind of walk you through some of the issues for smoking, blood pressure, cholesterol. I put in blue the ones that are sexually different. So for both men and women, has your father or brother had a heart attack before the age of 55? That's premature. That's basically suggesting some genetic impact. Has your mother or sister had one before 65? That's premature. So the 10-year gap. And then the other one that's in blue is, are you 45? If you're a man, for men, that's a risk. And for women, are you 55? So we have this 10-year difference that we kind of build into our risk algorithms. And here you see this. So age is clearly the #1 risk factor. And there's nothing we can do about it, hopefully. Hopefully we'll all get to live as old as we can be. But this is actually dying here, so you're not on this chart if you're succeeding on that scale. But what you see is men are taking off, as I've shown you before women are, in terms of the impact of age. Probably you've heard about cholesterol in one of the other lectures. I'll just kind of remind you that when we talk about total cholesterol, it really doesn't mean very much, because there's a good component. The HDL cholesterol essentially is removing cholesterol from the arteries. It takes it back to the liver, and you basically repackage it in a healthier way. And we do talk about having low levels HDL. So there's an optimal of 60 or more. We talk about less than 40 for men, but I really think that less than 50 is what we should be talking about for women. I think there's a sex difference there that we should be building into our algorithms. LDL cholesterol is the one that's actually depositing in your arteries, and so this is where a lot of the risk management goes. We do have really good drugs for treating that. We don't have such good drugs for the HDL. And then triglycerides is this interesting thing that it does matter for women, but it's not given very much credit because it doesn't seem to be as important for men. When we talk about blood pressure, I'm just going to point out that this slide, to orient you, is here's white men, white women, black men, black women, Mexican American men, Mexican American women. and that African Americans have much higher blood pressure than do the other two groups. And in fact, when we talk about hypertension, African American ancestry is a risk factor by itself. Obesity, overweight for all of us, sedentary lifestyle, alcohol, sodium intake, we really want to get that down, and insufficient potassium. So these are some of the major risk factors for this huge problem. Now it turns out in women, the Women's Health Initiative also had a huge observational study, so we have lots of other data besides the hormone trial. But there was they defined pre-hypertension, and that was actually shown to be independently associated. So pre-hypertension is essentially you're not yet hypertensive. Oh, I don't have the, yeah, here we go. So pre-hypertensive, instead of being above, it being up to 139 over 140 over 90, we're 120 to 139 over 80 to 89. It turns out that that's also giving you increased risk, certainly not as bad as being full-blown hypertensive. So this is your risk of getting a coronary heart disease over the course of the follow-up study. And you can see that pre-hypertension was about 66% more likely to be getting a heart attack, or one of these events. So it could be an MI, it could be a stroke, it could be heart failure, it could be cardiovascular death, whereas hypertension was 2.89. We don't have data quite as good as that for men now because we actually have this big study of women. One of the points I want to make with this slide is that for both men and women, and you can see here that this is giving you a much higher scale for men than for women. So the blood pressure issue actually is quite important for men as well. This is giving you the kind of now, I guess, what we'd be calling pre-hypertensive, borderline, and then high. This was old data when we had even higher rates that we tolerated. Now we pretty much start with the green. But you can see that it's a very dose-response situation for both men and women, and it's true for coronary heart disease. Stroke is increased with blood pressure. Peripheral vascular disease is increased with blood pressure, and congestive heart failure in both women and men. Now, in terms of the smoking rates, women do smoke less than men. Not quite as good for whites. White women have higher rates than the other groups. And also blacks are not that far below. But the good news is Asians are really low for women, and also Hispanics. And so this is just the smoking rate that we know is very much related to heart disease. Now, an interesting issue for women is if women have diabetes, their risk for heart disease is much higher than if a man has diabetes. So this is a big sex difference that has been showing up over and over. This is actually pre-diabetic, so this is actually just impaired fasting glucose. So even within that, whether you use old definitions or new definitions, what you see is that for women and for men, your risk for coronary heart disease is much higher if you're diabetic, or if you're impaired fasting glucose, and for women, cardiovascular disease as a big group. So this is also now seen as an independent risk factor to have these high blood sugars. And also, if we talk about risk factors, for prevention, it's really hard to do everything at once. And so what we kind of recommend to people is to realize that as you add the risk factors, so you go from really no risk to total cholesterol being elevated, that increased the risk for both men and women. Cholesterol and blood pressure increases it even further. Add smoking, you increase it even further. Add the bad glucose, bad blood sugar, you increase it even further. And if you actually have left ventricular hypertrophy, you're really in a really high place. Men and women look quite the same in terms of adding these up. And what I was going to say is if you can't do it all at once, any one of them will reduce you and move you back down. Focus on where you can to just reduce your risk, and that's true for men and for women. When we talk about diabetes, it's kind of interesting because it depends on what race, ethnic group you're in terms of whether men have more or women have more. In the case of whites, diabetes is higher in men than it is in women. In the case of blacks and Mexican Americans, it's higher in women than it is in men. And these women also have higher obesity as a group, and so that's part of it. Now, as I mentioned, If a woman has diabetes, she has much higher risk for cardiovascular events, with one exception, and that's stroke. So what you're seeing here is women, if a woman is diabetic compared to a man, their risk going above this line of 1, and my pointer's kind of dying out here, this line of 1, you see that women have higher risk for all cardiovascular disease, also for coronary heart disease, for heart failure, for intermittent claudication, and it's really only stroke that is higher for a male diabetic than a female diabetic. So diabetes is a really serious issue for women. This is kind of saying another version of that. We've done a much better job of bringing diabetes down in men. So men with diabetes, actually, we've been able to control their risk for heart disease. So if you can see, basically, in 1971-81, they were much, much higher than they were by the time we're in the 1988-2000, whereas women, nothing changed. And this ratio of not diabetic to diabetic, really, it's lower in women than it is in men, but it's not improving, whereas men are. So this is a serious issue for us. So in summary, those risk factors, age, cholesterol, blood pressure, smoking, diabetes, and having had a heart attack before is a huge risk factor. And then the other set is is family history, which we mentioned already. And I want to say a little bit now about lifestyle factors and something called metabolic syndrome. Metabolic syndrome is having any 3 of the following 5. So you see what they are, but I can show you here. This is a classic case of what would be at high risk for metabolic syndrome. So abdominal obesity for men, it's a waist of 40 inches. For a woman of 35 inches. If you're metric, you can read that. Triglycerides of 150 or higher. Ldl-Cholesterol below 40 for men, below 50 for women. So the metabolic syndrome does build the 50 in instead of the 40. Blood pressure, not hypertensive yet, but close, 130/85. Fasting glucose, not diabetic, but high. And if you have any 3 of those 5, then you have metabolic syndrome. And I will point out that when we talk about women with metabolic syndrome, they're much more likely to look like this than like that. And what we know is that women who have the android obesity pattern, the male pattern for obesity, if they were matched for obesity level, so they had the exact same body mass index, this woman would be much more likely to have a heart attack, to have coronary heart disease, to have high blood pressure, diabetes, low HDL, high triglycerides, gallbladder disease, specific cancers, than the woman with a gynoid pattern. And we've got lots of really interesting data now that essentially the fat that this woman is putting on is primarily subcutaneous. Much of it is in her thighs and in her hips, and that turns out to be a pretty safe place to put extra fat. On the other hand, this woman and that man have most of their fat intra-abdominally in a fat depot that will release directly into the portal circulation, which goes right to your liver and causes all kinds of metabolic problems. And so there's a different physiology depending on where you put your fat. And this is one reason why men have higher risk, because they tend to put their fat in the male pattern. But if a woman is in this particular kind of pattern, she's at much higher risk. And this is generally the woman who's showing up with these younger heart attacks and other kinds of problems. And by the way, you can't change that where you put your fat. That's a genetic predisposition. And here you're seeing that if we talk about someone with metabolic syndrome, the likelihood that a woman's going to have cardiovascular disease is substantially higher than for a man. But for both men and women, this is significant. And I know I'm showing you a lot of kind of data that you probably don't completely follow, but this confidence interval means that these are both significant, and the women are slightly higher. I think you all know that we have an obesity epidemic in the US, and that we know that it is associated with some of these risk factors that I've already talked about. So we're very clear that obesity increases our risk for hypertension, threefold relative to normotensive. It increases our risk for the low HDL and the high triglycerides, and it's threefold higher risk of diabetes if we are obese relative to normal weight. And when we talk about the relationship of obesity to physical activity, which I spent at least 10 years trying to sort through and finally just gave up and said, you know what, they're just so highly related. They're also related to all kinds of obesity comorbidities. So physical activity and obesity have some similar physiological, reciprocal physiological activities. But if we look at women, first of all, more adult women in the US have obesity than men. The good news is they're putting it, more likely they're putting it in the safer way, but the bad news is it's still having an impact, so that if we were to look at a woman who's normal weight and physically active, and we set her as our reference group, if that woman, the normal weight woman, is less active, she increases her risk of, this is multivariate risk for coronary heart disease, 32%. And if she's really sedentary, that goes up to almost 50%. But if she's obese and she's active, she still is at higher risk, 2.5. But if she's obese and sedentary, she's up to 3.44. So these interact. And again, if you can't lose weight, exercise, because you get some benefit from that. And weight loss is a lot harder than going out and doing the exercise. In the Women's Health Initiative, we also were able to show by quintiles, just walking, that the women who, so we set here the women who were at the lowest walking level as our relative group, and that what you're seeing in this is the decreased risk by becoming more and more physically active. So the women who were in the highest quintile had more than 50% reduction in their likelihood of getting coronary heart disease over the course of this follow-up period. And we actually had enough power, statistical power in the WHI to say that this was true of blacks as well as whites. It was in the same direction for the other ethnic groups, but we didn't have quite as many. And also it was true across the body mass index groups. So that was also true within obese women who were physically active had half the rate of coronary heart disease as the obese women who were sedentary. So again, being fit, even if you're fat, is a much better thing to do than just having both of those things out of whack. The data on physical activity continues to accrue. We have lots of good data to say that it lowers your risk of early death, of coronary heart disease, stroke, blood pressure, lipids, diabetes, cancers, preventing weight gain, and helping you with weight loss, and depression, and also cognitive function. And so I just want to kind of be sure you know what the guidelines are. I think most of you know that we talk a lot about getting the aerobic activity, moderate level aerobic activity, but there's new literature coming out that's fascinating on inactivity. The fact that when you sit without standing, your risk of coronary heart disease goes up, except that there are 4 additional pieces. If you can't do the 150 minutes a week that we recommend for for moderate intensity, then do what you can. Balancing exercises to prevent falling are built into older adults. Relative intensity basically means that what might be a slow walk for me feels like a jog to you, and that's all that matters. That basically you go with your own relative experience and check your own heart rate, and eventually as you train you'll be able to go a little faster, but not to think that a 3-mile-per-hour walk is what I have to do. That might be the max of your particular fitness level until you get more fit. And the only other thing I'm going to say about the new guidelines is that when they talk about weight control, in all the guidelines they kind of say more is better. So we don't talk about 150 minutes a week is good, that's the minimum, and more is better. And more is also better for weight. So that's all I'm going to say about that. Now, as I mentioned, we've got this obesity epidemic, so we've got lots of states that used to have relatively, well, that was pretty high obesity, 10 to 14%, but now it's outrageous where some states are, actually this is even old now, we have some states that are up to 30% of their population is obese, not just overweight, obese. But what's going right along with it is the diabetes trend. So we're seeing almost within 1 year of the states converting to having a higher percent of their population being obese, having a higher percent of their population having diabetes. And so what I wanted to show you is that we have some evidence that lifestyle actually helps men and women. There's actually several studies, but the best one that we hear a lot about is the Diabetes Prevention Trial, the DPPT, which had 68% women, 45% of the whole study were minorities. They were a mean of 51 years of age, and these did not yet have diabetes, but they had this high blood sugar that I showed you a slide that's associated with increased risk for coronary heart disease. And they had a goal of losing 7% of their body weight and doing this with a diet and exercise. And the diet was a heart healthy diet. We change what that means all the time, so that's why I'm just going to not talk about that at the moment. But vegetables is a great thing, and low fat, low saturated fat. I don't think anyone questions that. And so basically this was almost 3-year average follow-up, and they were looking to see how many of these people actually converted or developed diabetes mellitus. And the interesting thing was there was a placebo group, a group that was taking metformin, which is the leading drug for treating the blood sugar, or this lifestyle intervention. And the bottom line was lifestyle won, heads over tails over the leading medication. And that was true in men and women. So what you see here is the placebo in red. This is everybody, so those were the data I just showed you. The bottom line was the physical activity was the 100 minutes a week that we recommend, moderate intensity or vigorous. You can mix them up too. You can do 75 minutes of vigorous, or you can mix them up. They lost 12 pounds on average. This was the metformin dose, and what you see is in both men and women that metformin was successful, but not nearly as much as diet and exercise. So this is kind of a whole new phase where we now have good randomized clinical trial data that diet and exercise lifestyle will reduce our risk for, this case, diabetes. Now there's a huge study underway called Look Ahead, which has taken diabetic men and women, and they're coming near the end. They're trying to prove that by having diabetics do the diet and exercise and weight loss, we can prevent heart disease. So that study will be coming out in the next couple of years, so look for that. So the bottom line is when we talk about prevention, how do we lower CHD risk? We don't want to change we want to keep aging, at least I do. But we do want, when we talk about LDL cholesterol, this is where diet plays its biggest role. We want to have low saturated fat, high vegetables, fruits, whole grains. I did stick on here meds because it's pretty hard to not get out of the doctor's office without that prescription. But you could try and talk them down a little bit and say, could I try diet and exercise for 6 months and see how it goes? And that's what I would encourage you to do. For HDL, we talk about weight loss and exercise. We don't have a great diet to take care of it. For blood glucose, we talk about weight loss and exercise and reducing simple carbohydrates. For high blood pressure, we talk about weight loss and exercise. For some, reduce salt and reduce alcohol, and smoking, stop or cut down. So weight loss and exercise is kind of the big story. And the most amazing thing is, I was sitting there thinking like, I thought that I had come to the end, but I didn't. Okay, good. So symptoms. We're going back now to women and heading into the issue of women report greater symptoms. They often, they have a greater number of less common symptoms. So it's not the same thing if you have a heart attack. It's not the same thing that most men will talk about, this elephant standing on my chest. Some women will have that, especially older women. But there's really a lot of other things. So they'll talk about shortness of breath, nausea, vomiting, transient, non-specific chest discomfort, arm and shoulder. It's usually in the left, but sometimes it's in the right. Abdominal pain, indigestion, back pain, neck pain, jaw pain, headache, fatigue, dizziness. All these things, and women can report many of those. And none of them may give the tale. None of them may be the giveaway. Now, I can tell you that men do report more chest pain and belching and hiccups. So I don't know if that's because we're trying to snuff it or what, but at any rate, there you go. That's one of the sex differences. But also, both of them are pretty likely to have exertional symptoms, so if you start to exercise. But in fact, women will have more pain when they are at rest and during sleep and with mental stress. I'll also note that for menopausal women, or premenopausal women, they may have worse symptoms in their menstrual periods. Now, an interesting issue is for women who are having these events, these symptoms, 95% of women report these before they've actually been diagnosed, before they have the heart attack. And I can tell you one of the things that we're going to move into now is the fact that many women will go and they'll get a full workup and they'll be told there's nothing wrong with you, go home, and then they have a heart attack because there was something wrong with them, but we didn't understand it. Most women will have an average of 5 symptoms. The most common is fatigue, sleep disturbance, shortness of breath, indigestion, anxiety. Well, we have those things all the time, so it's really hard to distinguish that from a heart attack. Only 30% will report chest discomfort, and this will go on for a month before they actually have their heart attack. So this is a challenge, and this is something actually Stanford is really aware of. Jennifer Tremmel, if any of you have heard that name, has a wonderful women's heart health clinic. So she really caters to women's cardiovascular issues, and I'm going to show you some of the things that she does. Now, some of the things that are a challenge is all of our tests are male-driven. So the tests that we have to distinguish and determine heart disease, the exercise treadmill turns out to not be very good for figuring out that women have a heart attack. It's much lower specificity for women compared to men, really high false positive rate, and so often a woman will get a special kind of exercise test, but if she just gets a regular exercise test, you're going to miss it. Stress echocardiography and nuclear perfusion scan, the sensitivity is similar, but it's not great, and so on and so forth, that when we talk about some of these other issues, we just don't have good tests. Now, actually, Jennifer has some good tests, so I'll mention a few of them. But I want you to know this term, acute coronary syndrome. It seems to be what most cardiologists are calling these MI, so when we talk about STEMI, we're talking about myocardial infarction. So this is either ST elevation or non-ST elevation. And we go through a series of asymptomatic to then stable angina, and we talk about angina in a moment, to then unstable angina, and then we move into the acute coronary syndromes of the non-STEMI and STEMI. And the reason why I want to show you that is that when we talk about women compared to men, as a group, they come in, they're older. So we already talked about the 10-year age difference. They have more comorbidities. They've got a lot more hypertension. They have higher cholesterol. They have diabetes. They basically fall into a group where you have to manage lots of other things besides just their heart disease. They're much more likely to be depressed before and after their diagnosis. They're more likely to have heart failure than a man. They're more likely to have a history of chest pain, angina, and more severe angina. They're less likely to present with this, the ST elevation MI, and they're more likely to have no obstructive disease. And that's what we're going to get to in just a moment. I'm still going to go through a little bit more list here. They present later, so that's kind of the older thing. They're slower to receive treatment. That's not their fault. That's the medical system doesn't realize they need to be treating these women. They're less likely to get the guideline-based medical therapy. Now, a woman who's got heart disease, aspirin is fine. We're not talking about primary prevention. We're talking about managing a disease that's there, and also they're less likely to get statins. They're less likely to have an angiogram and to get revascularization, but there's some good reasons for that I'm going to show you in a moment. They have much higher rates of severe bleeding, especially with some of the procedures. When you get an angiogram, they actually thread a catheter. They usually thread it up through your femoral artery. It actually turns out, I'll show you some data, that going through the radial artery is a much better thing for a woman and actually better for a man. And Jennifer Tremmel has taught all of the cardiologists at Stanford to do it that way. They're less likely to be referred for cardiac rehab, and they really need to go to cardiac rehab. Now, a lot of women don't find it a very good environment because they're kind of, one or two women in the group, and so this is a little bit of a challenge, but they really should be referred to cardiac rehab, and I'll show you that they have more death. So this is this radial versus femoral access issue. And basically, there have been some studies now to show that you have this major bleeding that occurs with the radial. And it's, I guess I don't have the scale here, but this is men and this is women. So for women, it's much, much higher bleeding. But also, when you go through the wrist to get this catheter threaded, you see that men also benefit tremendously as well. So this is a case where, in trying to solve the problem for women, I think that we've really done men a great service, and I think that that's what we're going to keep having as we do sex difference research. This is kind of showing the same basic thing, that basically bleeding complications are much higher in women than they are in men, actually, these are two different kinds of things. So this is looking at the angioplast, right, and radial versus femoral. So you can see this difference. So again, women are much higher than men, but also the radial versus femoral. Also, vascular complications are much higher in women. So these are big issues, and these are issues that I think Stanford's really taking on in a serious way. Now, there's an interesting paradox, and I alluded to it earlier. And this paradox relates to the fact that although I've already shown you that when we talk about having coronary events, women versus men, that men are clearly having them at earlier ages than women, but there's another side to this story, and that is if a woman's had a heart attack and is put in the hospital, the younger she is, the more likely she's going to die than if she's an older woman. And this relates to the fact that we're just blind to the fact that young women could possibly be having heart disease. We just don't get it. Whereas older women, we're kind of ready for the fact that, hey, this could be a heart attack. And this is actually showing the odds ratio for death during hospitalization for a myocardial infarction in women versus men. And what you see is these younger women have twofold higher rates, and then as they age, they get closer and closer to men. So this is a big issue that we need to start to understand how to identify these problems in young women. And this is kind of one of the original studies to look at this, Vaccarino, where you see in the young women, so this is women in red and men in the blue, that this is the death rate, this is myocardial infarction, this is actually looking at the hospital mortality, so women who died compared to men, and you see that young women are much more likely to die than young men, but as we get older, then it kind of evens out. And so this is an interesting issue where we've got now this hormone story that's a little bit different for young women versus old women, and then we have the entire medical management problem, which isn't just medicine, so it's not just gendered medicine. I'll show you some data to show you that we've got some different biology. But this is looking at that sex ratio. This is kind of the same basic story, looking at the hospital deaths, and that this is actually your odds ratio. So if you're younger than 50 and you're a woman, you're more than twofold more likely to die because of your myocardial infarction after you're in the hospital than a man of your age. And you're better off if you're 80 plus, which again was when most of them are happening, but still. And this is kind of the same basic thing, just kind of giving you another picture of that even when you adjust for all kinds of things. So this is one place where a lot of attention is going now. And this is true when we talk about coronary injury, also bleeding. Younger women just have a much worse outcome than do older women in our hospital setting, in our medical system. And this is kind of more of the same now, looking at major in-hospital complications. And so what you see is younger women in black, they fare the worst, compared to younger men, older women compared to older men. It's not so bad for these complications up here. Now this, I don't expect you to really see what's going on here, so here's the story. But bottom line is 74 population samples were built into this huge database. This is the line of identity, so anything that falls on that means that it's the same, it's kind of equal. And basically they had 13,331 angina cases in a huge sample of women and a huge sample of men. And the bottom line was chest pain is much more prevalent in women than it is in men. And this is something that now you see, it's kind of hard to actually pull that out of those data. But the ratio is about 1.4 among Americans. Non-whites are higher than whites. But this chest pain thing is a really interesting phenomenon. Many women will go in with this chest pain, and what we do with chest pain, the first thing that usually happens is you get an angiogram. And the angiogram turns out to very often not reveal any coronary disease in women, whereas most of the time it does in men. So 87% of the time that a man has a chest pain and he goes in and he gets an angiogram, they actually find an occluded artery. And it's about 50% for women. So they get sent home. And this is actually something that generated a huge study that women who come in with these symptoms of angina are less likely to have obstructive coronary artery disease. And so they're sent home with a clean bill of health. But in fact, a study was done called the WISE study, so Women's Ischemic Stroke Evaluation, Syndrome Evaluation, trying to understand what is this chest pain? Why do women have it? What is it? And it basically required getting brand new technology to try and understand what is the real pathology going on here. It's not benign. They often end up with a heart attack, and it's a serious event. Now, this is just a schematic. I'm sure you've seen better from previous lectures. But to kind of make the point that as we get older, we start out with normal vessels. We start to get fatty streaks in the lining of the vessels. These fatty streaks, by the way, they see them now in 2-year-olds. So it's, I don't know if it's because of our bad diet or what. Fibrous plaque starts to develop. Then you get an occlusive plaque where if you go to put an angiogram in there, you actually see a 60% stenosis, and that will be then your definition of a plaque. You won't have a heart attack with that, but if it ruptures, then you end up with blood clotting and you have your heart attack, or you have your unstable angina, your coronary death, your stroke, your critical leg ischemia. At this level, you're already getting your effort angina claudication. And the reason why I'm showing this is that if you went in with an angiogram into this vessel, here this yellow is the plaque, and you actually can see that it's blocked. And you would see a block there, and the cardiologist would put a stent in, and you've probably seen that now in one of the other lectures. And if you actually were looking on the other end of the vessel and you were watching the pressure, you basically would see that there's this huge pressure drop right where you've got the blockage. It turns out that these young women, and these women with angina, where they go in and they don't see this occluded artery, they go in there and they just say, oh, women have smaller arteries. When in fact, they've got this whole case, this whole sheath of plaque narrowing the whole thing, but there's no individual blockage. And that's a real hard thing to stent. Now, I can tell you Jennifer Tremmel's really good at it. I'm sure she's trained many other people. But what you can see from the opposite, what you see from this is that this is a slow, steady drop. But the bottom line is you're going to have a heart attack here, just like you're going to have one there. You don't have enough blood. And there's now kind of a new movement ahead to redefine this. We call this generally coronary artery disease. There's a coronary vessel blocked. And where a lot of folks are going now with this one is they want to call it ischemic heart disease, because you still end up with no oxygen at the other end, ischemia, but you don't really have this kind of blockage that we are used to seeing. And so the angiogram is not going to pick this up very well. What they actually have now is several other methods. Before I say anything more, let me just say that when we talk about this, we don't, with the case of the classic ruptured plaque, where you end up with your blood clotting and then all the whole arteries occluded, this is very characteristic of older women and men. You have a thin fibrous cap that basically has a huge necrotic core infiltrating with foamy macrophages, so these are those things that are chewing up the area. Whereas the younger women have what we call erosion. Instead of explosion, they call it erosion, where you have a thrombus over a base of rich, smooth muscle, and the necrotic lipid core is often absent. Question?
Are the plaques in the ischemic artery disease still as unstable as in the top example?
You know, I don't think, so he asked, is the plaque that's in the more female type the young female type that we're calling the ischemic artery, is that as unstable? I don't think we have enough data to really talk about the stability factor of this. This is kind of new stuff, and the whole idea of ischemic heart disease is really the last 2 years people have been saying we should rename this. Now, some of the other causes of it, it's not just that problem. What they've also found now with these women with this type of ischemia is that they have endothelial dysfunction. Actually, both men and women have that. And actually, women have a better endothelial function than men. Generally speaking, it declines with age. But these young women who have this particular problem, they often have tests they can do to see that that can be part of their chest pain, and there are special tests that you can do to find that. I guess I took my IVUS picture out, but I'll go back for a second and just say that what they're doing now with these is there's something that's called intravascular ultrasound, where you actually can put ultrasound, you can put a guide wire down through the artery, and you can see the lumen, you can see the walls of the vessels, and you can really see that there's this plaque all the way along. And so there's some wonderful pictures that you can see, but you can pick this up very nicely. It's an expensive test, but it's a good way to find out that you've got that problem. And then the other one I'll just quickly mention is vasomotion, that there's a test you can do where you put acetylcholine in to see if, in fact, the artery will spasm. As I mentioned, that 160, well, this one is a study of 163 women that had suspected ischemia. 75% of them had no occluded artery. So they did the angiogram, they would have been sent home with a clean bill of health, and then it turns out that they show that they have this particular vascular reactivity, and that 50% of them also had endothelial dysfunction. So we're finding out that the pathology can be detected, we just need different tools, and the angiogram is not really good enough to do the job. So this is where we're now talking about ischemic heart disease in women. Basically, women develop this 10 to 20 years later than men. Compared to men, they have less severe coronary artery disease, so we don't see these big plaques. They have smaller infarcts. They have more preserved systolic function, but they have more symptoms, lower function, and more adverse outcomes after they've had the MI and the cardiac procedure if they're younger, probably because our medical system just doesn't know how to deal with them. And that's where a lot of our focus in the Cardiovascular Institute's interest is. So coming to a close here, is ischemia based on microvascular disease. So in addition, there's one more piece to this story, and that is the small vessels. So in the case of men, we focus on the big vessels, the big coronary arteries, and what we're seeing with a lot of these women is that they've got disease out in the small vessels. I took that picture out, I should have kept it in. But basically, it's much more common in women. And some of the things that you might know about Raynaud's disease, have you ever heard of that? So Raynaud's disease is something that's much more characteristic of women. It's a disease in which you actually have this vascular sensitivity that if you put your hand in the refrigerator of at a supermarket, you can actually get frostbite because it just completely shuts down. And so it's very common in women compared to men. Also, migraine is much more common in women than men. There's a real hormonal relationship with migraine. Actually, it depends on whether it's with aura or without aura. I'm not going to take you through all that. Coronary spasm is more common. So the bottom line is we have different physiology, different pathophysiology, particularly when we're talking about younger women. Retinal microvascular abnormalities predict cardiovascular disease in women, but not in men. So this is a place where we're getting more and more information that I think will be able to do a better job for women. And with that, it looks like I could have kept, another 20 slides, but I didn't. So basically, I'm going to end with the bottom message that applies to men as well as women. When we talk about prevention for coronary heart disease, and when we talk about prevention, by the way, I'll just quickly say something. In cancer, we talk about primary prevention, trying to prevent ever getting it. And we say the same thing for coronary artery or for heart disease. And then in cancer, we talk about secondary prevention, which is the screening and detecting and diagnosing. Whereas in heart disease, we call secondary prevention, you've got the heart disease and you're trying to prevent another one. And then tertiary prevention, we talk about in cancer, where you've got the cancer, it's detected, and now we're trying to control it and manage it and keep you out of a crisis. And that's kind of where the chronic health, the chronic disease model is going. We're talking more and more about tertiary prevention, where if you've got the disease, we're trying to keep you out of crisis. And so when we talk about this, it doesn't matter what level you're at, whether we're talking primary, secondary, or tertiary. We really do have lots of evidence that whatever you can do physically, you should. That moving is good. And we move very little now. Everything is buttons. I mean, you all remember when we used to wind up our car windows. Nobody does that anymore. I mean, that was one little movement that we had. And there's just like one after the next when you start to think about how you just don't do anything anymore. You just push buttons everywhere. So be physically active, maintain a healthy weight. Vegetables, I think, is more important than fruits and whole grains, but those are good too. Restricting saturated fat, limiting your salt. We have data on this for women. We have data on this for men. As I said, I took out a lot of slides, and that's okay, because I think you probably had enough. Adequate calcium and vitamin D. Vitamin D is a big story now. We don't really have enough data on how that relates to cardiovascular disease in men or women. Limiting alcohol intake. Minimizing stress. It didn't bother me that we moved rooms. That was fine. Get enough sleep. That's one that I don't do, but hopefully you do. I can tell you the Stanford students don't get that one. And know your risk factors. So just out of curiosity, how many of you know your HDL cholesterol level? Just a few of you don't. How many of you know your LDL cholesterol? Good. How many of you know your blood pressure? How many of you know your blood sugar? Okay. How many of you know your BMI, your body mass index? Good. Okay. You're clearly an enlightened group here, and that's great. And then the important thing is how many of you are getting enough exercise? How many of you are watching your weight? Okay, so the bottom line is you all know what you need to do, and what I'd like to recommend is that you go home and do it. For women, I think what we realize is that we just need to keep learning more about us so that we can be sure that they learn what they need to do to take better care of men. So they can take better care of us too. Thank you. So actually, I remember the reason I took them out is that I was told that there'd be lots of questions. So here's the time.
I saw at the bottom of one of your slides, but you didn't mention it, sleep apnea as a risk factor.
Yes, it is. So actually, we're doing this amazing study right now in men. She said that she asked me about sleep apnea. So it turns out that sleep-disordered breathing and sleep apnea are certain things more important for stroke versus coronary heart disease and other things. So sleep disorders are highly related to coronary disease.
Is it the lack of oxygen when the apnea sets in so that the heart has got to work more?
You know, I'm not sure we really have a good cause and effect relationship there. There's an association, but I'm not sure which way it goes, whether it's the heart that's causing the sleep problem or the sleep that's causing the heart problem. And in some cases, sleep apnea is highly related to obesity. That's probably where you saw it. And in that case, the obesity factor probably is causing the sleep apnea because the weight on the chest. And when you go to sleep at night, you actually have like this whole phase of muscle relaxation. You're kind of paralyzed, actually. And so it's just harder to lift that weight off of the chest. So that's at least one of the explanations for that issue. Other questions?
Can you make a comment on the relationship between coronary artery disease and vascular dementia?
So vascular dementia is basically expressing, you know, when I had that one slide where you could see the blood vessel, and then I'm showing all the different things. Your blood vessels can have this plaque in them, whether it's in the brain, whether it's the cerebral vessels, whether it's in your leg and it's the peripheral vessels or the coronary vessels. And so when we talk about vascular dementia, essentially you're just not getting enough oxygen to the brain. That's the main thing, which is really different from Alzheimer's disease, where there's a really different kind of pathology. There are these tangles and things.
Did I miss, or did you not mention why the difference between men and women and the plaque, the way the plaque tends to build?
The answer is we don't know. I mean, right now we're just discovering that it's true. Oh, the question was, why is it that women have this sheath of plaque and men have this block plaque? Now, the first thing I want to just remind you is that older women tend to have the same kind of disease as older men. So it's not just men versus women. It's the younger women who are coming in with this chest pain and these women who have angina. So the answer is we don't really know. And we also know that it may be that, and it may be the microvascular disease, so the small blood vessels, and it may be the endothelial dysfunction. So there's at least 3 different possible pathologies, and I don't think we have very good data yet on how often those happen. I can tell you, I've mentioned Jennifer Tremolo a few times. She's actually doing this great study. The Y study only had women. And then the data came out and everybody said, oh, women are so different from men. But it's like, well, how do you know? You didn't have any men in the study. And so she's actually doing a study where she's looking at men and women. About 40% of the men that she's seeing will have this, about 40% of the people who have this coronary, this non-obstructive coronary disease are men. That said, almost all the time when men have chest pain, they have this blockage. But at any rate, she's found it really hard to find enough men in the study to even look at that. So we don't have enough data to say why are women different from men, because we don't even know yet that they are once you're in that particular category of disease. That probably wasn't a very good answer, but the answer is I don't know. But we're going to find out. I mean, hopefully we'll find out.
You talked about the young women going into the hospital and having heart attacks, basically. Is that because they were undiagnosed? Or
no, they were admitted for a heart attack. So these women are admitted for an MI into the hospital. But then what I was saying is that women who are admitted into the hospital with an MI, young women die at much higher rates than young men who are admitted with an MI.
why?
Well, probably for the reasons I've been saying. So one thing is they're misdiagnosed. Well, in this case, they're having their heart attack, but they're not treated right. They're not given the same quickness. The door-to-balloon time that I mentioned is a really important factor. And so you've got to be acting quickly, and they don't act quickly enough. So by the time they're in there, they've just, too much time has gone by. They're not treated as aggressively. When they have the procedures, they have more bleeding. They just have more complications. So it's multiple reasons.
So this sounds like an area where physicians need to be trained and educated better.
Yes.
Whereas many of these other things is we people need to.
Yeah, so he's saying physicians need to be trained. We all need to be trained because a big part of the problem is even before the ambulance doesn't come for you, the woman doesn't know she's having a heart attack, so she doesn't call the ambulance. And so we've been trying. They used to say that, oh, first she's getting dinner ready for the family and doing this and doing that. So we used to talk about that, and no one really had the data to prove that, so we stopped saying that that was true, but it might be true. But at any rate, women don't recognize that they're having the symptoms. Then when they call and they have these diffuse symptoms, it doesn't sound like an elephant standing on the chest. I'm not going to rush over there for you. Then I get to the emergency room and you have the same problem. So it's delay, delay, delay. And this is a big focus. And I can tell you when you say education, that's really the Heart Association's Red Dress campaign has been trying. And actually, we started this in 1989. In 1989, the AHA had a big campaign called Heart Disease is an Equal Opportunity Killer, trying to let people know that it could get women too. And that didn't work, so the Red Dress campaign came later. So it's a long, hard process to educate the public that women are at risk for heart disease, and then the physicians.
Is one of the reasons why you have We already heard that for the pediatrics. Is it
Yeah.
also true for women?
Well, I think that actually, I can tell you since I've been doing this for so long, that was where a lot of the focus was in the beginning. They were all talking about the smaller vessels, and they were using pediatric catheters for women. So they were, recognizing the need for the pediatric catheters, and they were using those. But I think that we've now moved to the point where that could be part of it for some women, but it's not the whole story. And then we have other issues like when we start talking about transplanting hearts. There's a lot of really interesting stuff that Stanford has done showing that when you transplant a woman's heart into a man and a man into a woman, it's just not as good as when you're transplanting them in the same sex because you have to change the blood vessels because that heart's not ready for that blood vessel. So there is a lot of size to take into account. But I actually think the pathophysiology is going to take a lot more time and attention for us to resolve as well. In the back.
Some of the slides you mentioned vegetables, consumption of fresh vegetables, fruits, and whole grains. I'm wondering why, if it was intentional or not, that you haven't mentioned plant proteins, legumes, tempeh, tofu, versus animal protein.
Yeah, as I mentioned, I didn't go into the diet part. There's like another whole prevention talk that I was saying to Sophie, we really should have a prevention talk. I tried to put as much of that into that. It would be better to get Christopher Gardner to tell you about all the legumes and all the different kinds of foods because there's a lot of debate and challenge. What I will tell you is the direction that the American Heart Association and the NHLBI are clearly going is not focusing on individual foods as much as diet patterns, and so that you're really talking about how your legumes and tofu and those other things would fit into the overall scheme of what you're eating. And actually, one of the slides that I showed you where they were taking apart the different blood pressure and tobacco and those different pieces, the same authors, Mazzafaran, has just done a really interesting paper in the New England Journal of Medicine on diet and the different parts of diet that really make a difference. And I'll just tell you, the thing that was really interesting was yogurt turned out to be like one of the strongest good things to eat, which none of us are quite clear why that's true, but it's an interesting, Mazzafaran is his name, so that would be a place for someone who's interested in diet. But diet is another whole talk. Anything else? Okay, well, thank you very much.
For more, please visit us at stanford.edu.